So now let's talk about non-neurologic causes of coma or loss of consciousness. So you have cardiovascular causes, and one of the most common causes is acute cardiac failure, and this of course can happen in the setting of all these problems that you already are familiar with. So either a patient may have myocardial infarction, a massive infarction, aortic dissection, hemodynamically significant PE or pulmonary embolism. They can be pericardiac tamponade and arrhythmias, and you can see the first two of these are going to result in cardiogenic shock. The following two are going to be obstructive shock, and then arrhythmia can be cardiogenic shock as well. So whenever you are seeing a patient, so this is going to be a little bit different from the regular situations where you are evaluating a patient for different problems. This is where you are going to probably be working in the reverse order. So your patient may already be in shock or coma, and you're trying to figure out what really caused it. And if you backtrack, you can finally find your path back into these diagnoses. So what happens is, in the history, let's say the patient is already in shock or coma, and you go back in history and you find out either from the patient's family member or somebody who knows about the history, that patient had prior to this situation had either chest pain, and again this chest pain can be any nature, and you all very well know now what kind of chest pains are going to be associated with all these different problems, and will have shortness of breath. And then on clinical evaluation, when somebody was evaluating a patient, let's say an EMS person or the first responder who looked at the patient, they would have found out that patient was hypotensive, tachycardiac, and maybe in the history there was palpitations and also some oliguria on assessment. So these are the things that you will find out if you go back in history and backtrack. Symptoms and signs will be consistent with these diagnoses. And because of this, because the patient is, you can see, hemodynamically unstable, these things will cause cerebral hypoperfusion. So see, it's not necessarily a stroke, but it is massive hypoperfusion of the brain. So brain doesn't get enough oxygen because there is not enough cardiac output for whatever the reason, and finally people will go into coma. So you will work in the reverse order in these situations, but this is how you can figure out what the underlying cause was. This is just another slide showing pathophysiologic mechanism behind systolic versus diastolic dysfunction, and ultimately causing ischemia and further cardiovascular compromise, and then leading to shock and death. So this you don't need to go into detail here, but the next is the further breakdown of what really labs and tests will need to be ordered if you're suspecting these injuries. So of course you already know EKG, troponins, cardiac enzymes, CKMB, CT scan of the chest, echocardiogram, and EKG again for the last diagnosis. So all these orders or the tests and labs will be extremely important when you're considering these diagnoses. So remember that all your orders must be because of some consideration of a diagnosis, so not randomly ordering everything under the sun. Then again, more specifically, if you were thinking about cardiac ischemia, and here this is just a quick review, I'm not going into the detail. Of course, the patient would have said all of these things about the chest pain, and you would have seen all these risk factors in the past medical history, or if you are reviewing the patient's chart, and then you would have seen that the patient had normal cardiac exam, and then this is just a copy of the slide from the previous topics. And then this is a slide showing a massive MI on EKG. The patient had a lot of cardiac decompensation, and ultimately resulted in cardiogenic shock and coma. And these are the enzymes to order. Again, just a quick review. And you already know about aortic dissection, so we already talked about it. So the patient would have said prior to losing consciousness that he or she had severe chest pain, and then all those things that result from aortic dissection will lead to hemodynamic compromise. So you can see that how this was a red flag situation when we were discussing this aortic dissection in the previous topics. So when the patient gets to this point that they are hypotensive or tachycardic or tachypneic, then obviously this is going to be a guarantee for cardiogenic shock unless something is done very quickly. So this is why this hemodynamic stability is very important. And then again, in the history you will find these risk factors. Again, this is just a repetition. And then in pulmonary embolism case, again, you know all of these things. These will be the symptoms and signs, physical exam findings, and the labs and tests. And these are the risk factors you will find in the setting of pulmonary embolism. And the treatment would be, of course, heparin. Now, here, if a patient did not have any risk factors like surgery or immobilization period or anything like that, and so basically we say the patient had an unprovoked PE, so basically nothing provoked the pulmonary embolism, then these patients should definitely get lab evaluation for protein C and S deficiency, antithrombin 3 deficiency, and factor V ligand mutation. So these 4 labs must be drawn for these patients, because this is the only way you figure out what caused it. Otherwise your patient will be at lifelong risk for getting another PE and maybe dying from it. And then again, you can see if this patient becomes hemodynamically unstable or the embolism is very massive. For example, it's a saddle embolus, or it's occupying a large part of the lung, then it will result in obstructive shock. And as we know from hemodynamics of obstructive shock, that people will ultimately have very low cardiac output and are going to die from it. This is just a quick EKG. Again, you already saw that. And then again, a pericarditis patient, typically it can be a very benign condition. People may not end up with any serious outcome, but this, if untreated and if it goes wrong, can result into pericardial effusion, cardiac tamponade, and finally cardiogenic shock. And as we recall from our shock hemodynamics, that this will be initially obstructive shock because there is a lot of obstruction in the chest cavity, but then finally results in decreased perfusion. And whenever there is cardiogenic shock, it will cause decreased perfusion in the brain, and people can die from it. The next is a chest X-ray showing pericardial effusion. So you already, this is another copy slide from the previous talk, and then echo showing effusion. This is an arrhythmia. So just like long QT syndrome, there can be VTAC or ventricular tachycardia, polymorphic ventricular tachycardia can show like this, and this again will be a non-perfusing arrhythmia. So we call these non-perfusing arrhythmias because these in these arrhythmias heart is working, it's jumping up and down, doing everything it can, but heart beating is not resulting in any perfusion of different organs in the body. So that is why people end up with cerebral hypoperfusion, and although blood is circulating but it's not perfusing, it's not getting to all the parts of the body, and that's why people go into coma. Then there are respiratory causes of shock. So of course any respiratory failure, so anything, any respiratory disease, if it goes wrong, it will ultimately result in respiratory failure and can cause shock. So again, a quick review of everything. So putting all things together, we have as simple as or as I guess benign looking as upper airway obstruction, COPD exacerbation, pneumothorax, which is quite common and can be very benign, but pleural effusion, pulmonary embolism, and ARDS. All of these things can be very self-limiting, very benign, easily treatable with intervention or medicines. But if they don't go right, if they don't go in the right direction, or the body does not compensate, people can go into respiratory failure from basically all of these. So in the history, if let's say somebody comes in and they are in shock and in coma, and you are looking at their respiratory status and they are in failure, you go back in history, you may find some of these diagnoses, or you may find some of these symptoms and signs that they might have complained about. So there may be chest pain, dyspnea. On physical exam, they may be hemodynamically unstable. They might have used extra muscles, or they may be cyanotic. So all these findings are consistent with these diagnoses, and if you see any of these are your clues in the history that this is in fact a respiratory failure causing altered mental status. And again, the reason for this, why it does that, is because there is cerebral hypooxygenation. So in cardiac failure, there is cerebral hypoperfusion, and in respiratory failure, although the heart is doing its best, but there is cerebral hypooxygenation, and then this patient will go into coma. And then this is just a quick thing to say that difficulty breathing or inability to breathe can be 2 or 3 different things. So it can be central nervous system depression, or anything that's causing CNS depression, or it can be just the problem with the apparatus or the batteries or the machinery. So most of the time we encounter these situations where people can't breathe. So there is a problem with the airway or the pleura or the wall, or can't breathe enough. So there's a problem with the lungs. So these people will be tachypnic. They are trying their best. They will use as many muscles as possible. So their respiratory rate will be high. Although high, it's not oxygenating. So that's how they go into failure. But then the other category, which is not as common, is central nervous system depression. So anything in the central nervous system that is suppressing the respiratory center will cause hypopnea. So these patients will just won't breathe. So they won't breathe, and that's how they will go into respiratory failure. So remember that decreased respiration does not mean it's not a respiratory problem necessarily, or it will basically mean that it's a CNS problem. And you can remember, like, your Cushing triad patient had hypopnea because there was a lot of pressure in the cranium, and they had bradycardia because of that too, and that's how they were in shock or in coma, and they had hypertension because of that. So this is, and then some drugs can cause respiratory depression at the central level, so that's how they get respiratory failure too. So there are 2 different categories of respiratory failure from the standpoint of I guess symptoms or pathology. And then real quick things. So what are the labs and tests that might be done for this? So of course, whenever you see somebody possibly in respiratory failure, you will always check for oxygen level. Therefore, oxygen is, or pulse ox is a part of vital signs. That's why it is vital, because you get the first-hand information. You know if the patient is oxygenating or not. So these patients will be hypoxic. Their PO2 will be less than 60. So this is basically not the pulse oxygen, it's the arterial oxygen level. So this will be less than 60, and then pulse ox will be much lower as well, much lower than 90. And this will basically, you will find out on ABGs or arterial blood gases. So keep that in mind. And then on ABGs or arterial blood gases, when you draw it because you are suspecting your patient is in respiratory failure, there will be elevated PCO2 or hypercapnia. So the number will be more than 45. So I think you already know 60 and 45, these values for being hypoxia and hypercapnia. Oops. Okay, this should have been like this. Anyhow, so this patient will come in. Okay, let's see. So whenever you're evaluating somebody for respiratory failure or any failure that makes you think that, okay, maybe arterial blood gases are not sufficient or adequate, of course we will draw ABGs. So anybody who comes in with altered mental status, ABGs is the essential part of the lab. So arterial blood gases will basically show this picture. This is a table showing what happens to pH, PCO2, and bicarb in the cases of 4 different abnormalities. In the best way to remember this, or one way that I remember this, would be remembering ROME. So just remember ROME. ROME means respiratory opposite and metabolic equal. So you have respiratory acidosis and respiratory alkalosis. This is going to be opposite, and metabolic is going to be equal or in the same direction. And this is how I can explain it. And I'm sure most of you already know this, and maybe some of you already remember it like this. But respiratory opposite means that, okay, in the case of respiratory acidosis and respiratory alkalosis, lab values will look like this. So whenever it's respiratory, we always look at pH and PCO2 greatly. So, and whenever there is metabolic situation, you are going to look for pH and bicarb levels, and it will be either metabolic acidosis and metabolic alkalosis. So how do we differentiate? Well, this is how you differentiate. In case of respiratory acidosis, pH is going to be low, and PCO2 is going to be high. So again, because it is acidosis, pH is low and PCO2 is high, so that's how they are in the opposite directions. And bicarb don't really matter as much, but they are going to try to go up if the patient is compensating. Then in the case of respiratory alkalosis, pH is going to be high, of course it's alkalosis, and PCO2 will be low. So this will be a situation where patient is trying to overbreathe, or they are, for example, in a case of a panic attack, when they are hyperventilating for whatever reason, their pH is going to go up and PCO2 will go down, and that is consistent with respiratory alkalosis. So you can see how these two values are going to be opposite to each other in these situations. And bicarb is going to try to be down if they are trying to compensate. Again, these are not going to necessarily mean too much, these values, if the patient has not compensated, and you don't obviously know at what stage you are drawing these labs. So try to focus on pH and PCO2, and you can come to a conclusion based upon these numbers. In case of metabolic acidosis, your pH is going to be low. Obviously it's acidosis, and then because it is a metabolic is equal, so the direction is going to be the same. When you look at the bicarb, it's going to be also low. So if the bicarb is low and pH is low too, then it's a metabolic problem, and you say, okay, it is metabolic acidosis. And if the pH is high, then it's obviously alkalosis, and you don't know if it's respiratory or metabolic, but when you look at the bicarb numbers, bicarb values will be high, and that will constitute as metabolic alkalosis. So this is how you can remember this table. Become very familiar with it because it will come again and again. So respiratory acidosis is going to be opposite, pH down, PCO2 up, alkalosis, pH up, PCO2 down, and you will look for PCO2 values because bicarb is going to be either normal or different if they are trying to compensate. And in the metabolic acidosis or alkalosis, things are going to go in the same direction or equal. And of course, your clinical scenario will help you a great deal figure out what's happening with the patient. So for example, if the patient took a bunch of drugs that caused any of these phenomena, then you can link your disorder to that drug problem. But we'll talk a little bit more about it here. So before we move on here, so a real quick thing about another few causes of respiratory failure, and you already know about angioedema. So of course it can cause upper airway obstruction, and finally will cause respiratory failure because of that. That's why it's important to treat the patient. So we already know this. Status asthmaticus will do the same thing. Patient will be pretty sick, and that's how you know. And then finally you'll treat the patient before they go into respiratory failure. So if we don't treat them, they will develop respiratory failure. As a result, their pH will be low and the PCO2 will be high. So this is how these patients are going to show. Pneumothorax patient, again, of course these patients will have hypoxia because of pneumothorax, and they have other abnormalities as well, along with the rest of the symptoms they might have talked about before they went into failure and shock, and they basically it results in coma. So their lab values will ABDs will be consistent with respiratory failure, right, or respiratory acidosis. So this is just a quick slide showing pneumothorax. So here is the patient with pleural effusion. So this can also cause failure. So of course, if the patient has massive pleural effusion that is occupying a big part of the lung cavity or the chest cavity, then it's going to result in hypoxia because the apparatus is bad. They just can't breathe or can't breathe enough, so therefore they have hypoxia and results in respiratory failure, and then finally respiratory acidosis. And here you can see pleural effusion. Then finally, ARDS is going to be probably the most common cause of respiratory failure in the inpatient setting. This is quite common. So this doesn't happen in communities or in a walking, talking patient. So your patient will be already sick, usually in the ICU with something, and they don't have enough oxygen. So what's happening is they basically develop a lot of pulmonary edema, and they just cannot oxygenate well. So they have decreased tidal volumes and they get hypoxic, and that's how they go into respiratory failure.